want to thank the organizers for this opportunity. It's an honor, but I'm not sure if it's such an honor if after 20 years they keep asking me to talk about dead kidneys. I do take care of kidneys at work. So I'm going to talk about the failed allograft and how to recognize when they need to come out and when they don't need to. And I want to start off with a case that's a real case. It was actually a PCP case at our institution because the chief resident couldn't believe the presentation. A 59-year-old white female returns to dialysis 2 years prior to the acute event at Vanderbilt. She had lost the organ to CAN, or chronic allograft nephropathy, or IFTA, whatever terminology you'd like to use. The patient was at our dialysis unit complaining of low-grade fevers, graft pain, and pyuria. Was seen on urinalysis. The nephrologist locally had thought this was an infection and kept treating the patient. Blood cultures and urine cultures remained negative times 3 separate attempts. 3 different types of antibiotics were used without resolution. Finally, we were called about this patient and was referred back to the Transplant Center. And when the patient came to the ER, the patient was an extremis. The patient looked like she had an acute abdomen. They had called the surgeons. They were ready to take her to the OR for exploration, and I said, give her steroids. And everyone thought I was nuts. So we gave her 500 milligrams of solumedrol, and within 24 hours, she was 100% better. The patient had, when we look back, stopped her prednisone, which we had told her never to stop. Her local nephrologist refused to keep filling it. She never called us. She also developed a cold at some point, and that's important in the history. So there are patients who can have allografts that have failed for 10 years, and if they get something that's immunostimulatory, like a cold or any kind of immunostimulatory virus, often they will acutely reject a month or so later. The thought on this is that when you have a cold, you raise your MHC, you release interferon, that's what makes you have that shaking chill and that pain, and you raise the MHC on your cells and say, hey, I'm human and hey, I'm me, don't hurt me, when the natural killer cells are looking for invaders. Well, guess what? That human kidney raises its flag, which had been accommodated or forgotten about by the host for years, and suddenly that kidney gets rejected. So that was possibly part of the etiology of this. So after she was transferred, we gave her the high-dose steroid. She got better. We didn't take her to the OR right away. Our surgeons took her 2 weeks later, and then nephrectomy was performed. The pathology showed rip-roaring, vascular, and cellular rejection, which is not uncommon. And I'll talk about some of the retrospective data on this. So this patient had, and I'll get to this terminology early, graft dysfunction syndrome. This is important to recognize, maybe the most important thing to recognize as a general nephrologist if you're taking care of patients who have allografts still in them while they're on dialysis. So the failed allograft that causes chronic illness or inflammation is considered graft dysfunction syndrome. It can be due to thrombosis. They can have chronic stones. They can have repeat infections. They have acute rejection or chronic rejection even, or rarely malignancies. Malignancies are far more rare in certain series, as little as 1 to 5% of all renal cell carcinomas in transplant patients. Most of them occur in the native kidneys. The consequences of this are anemia and EPO resistance. So these, if you notice a patient that's requiring like 40,000 units of EPO a couple of times a week and they're still not getting the goal, that might be coming from the inflammation of the allograft. If you measure a CRP, that will often be elevated. And rarely, but if you don't get on this, the patient can rupture. And this graft that I just told you about nearly ruptured. You can die from this. There's an arterial bleed that can happen. So you want to catch the patient before that happens. Now, often early on, they're asymptomatic because the patient doesn't, this is a denervated graft. It's not their native kidney. So only if it gets inflamed enough feels it, do the patients typically will present in an obvious fashion. So you have to be on the alert. If they say they're starting to make urine again, which they hadn't before, or if there's blood in the UA or something like that, that could be a sign that they have graft dysfunction syndrome. Once they have this syndrome, once it's recognized, you should take them to a nephrectomy. You'll probably need the transplant center to get involved because a lot of urologists and general surgeons in the community don't want to mess with transplant kidneys. So what is the scope of the problem? Well, as we continue to do more transplants, which is a good thing. In fact, in 2018, in 2019, that data is not out yet, but over 21,000 transplants were performed. In a typical year, we do between 17 and 18,000 at all centers. And the incidence of patients with a failed allograft now exceeds 7,000 yearly. So this is not the people who die and take the kidneys with them. These are people who are still alive and have a failed allograft and have to go back on dialysis. More than 12,500 patients, last I checked, or 14% of the active transplant list, are patients who have failed allografts. And in 2017, 13% of all transplants that were performed had already 1 to 3 prior transplants, so some of them were working already on their 4th transplant. You're going to see more of this as we do better medical techniques, CATs, things like that, to keep patients alive longer so they can tolerate multiple grafts. You're going to see more of this because in 2014, the allocation schema changed, and patients are getting bonus points if they're sensitized, bonus points from the point of ESRD. So there are a lot of patients who are actually getting their 4th kidney before many are getting their 1st, which is a separate topic. You can invite me back next year, I'll talk about it. Despite this burgeoning prevalence of patients who have failed allografts, there absolutely, this is the crux of this talk, there absolutely is no or little consensus of what to do with their management. We know it's bad to fail your allograft. In fact, Canada, which claims to do better dialysis than we do, still has a higher risk of death on patients who have failed their allograft and gone back to dialysis versus those who have persistent function. So a working graft is a good graft. The risk of death is also higher for patients who have failed their allograft versus those who have never had dialysis. Now, that's not to say it wasn't a good thing to get a transplant for those 10 years. Overall, your outcomes are better compared to if you didn't get the transplant. But once you go back, time 0, on dialysis with a failed allograft, you die at sometimes 2 to 3 times a higher rate than the naive population. And lastly, graft dysfunction syndrome, for all the issues I mentioned before, could be a consequence as well. So what do we want to do? Well, it's supply side economics. Let's reduce the supply, find ways to slow down the loss of GFR. Unlike your CKD patients, where you can map a 1 over creatinine and you know, maybe 2 to 3 data points, you could figure out almost to the day when they're going to start dialysis. I've had some of my engineers figure that out. With the transplant population, it's not so easy because I've had patients who had creatinines of 1 and they don't show up for 4 months, normal visit, and you find out they are in great rejection. And because in the modern day, these grafts aren't as hot as they used to be because the meds are better, they tend to smolder their rejections. They show up with creatinines of 15 and they need dialysis right away. So obviously it wasn't on me that I didn't know that they were losing their allograft. But a lot of these patients are like CKD patients, and you know that it's coming, it's just a matter of time. So things you can do that have some evidence, like I said, nothing's great here, but one thing is diet. So lowering dietary protein to a reasonable level seems to help these patients. I don't know what's going to happen with all these ketogenic diets. Everyone wants to lose weight. But basically, if you eat a lot of protein, like more than 1.4 grams per kilogram, you actually increase filtration. Hyperfiltration is a mechanism for us to get rid of the waste. But if it's you developing in a single kidney model, worsening CKD, you actually progress faster. So there's a couple of good studies out there that do show slowing of progression if you keep them to a more reasonable number, like 0.8 grams per kilogram protein. In addition to that, dietary sodium matters. There's direct vascular damage from it, glomerular hyperfiltration and hypertension. And in some studies, keeping them below 2 grams per day of sodium, especially when they're advanced CKD, has benefit. Less than 3 grams when they're earlier on. But in general, there's no benefit to really eating excessive amounts of sodium. Blood pressure control, there's 2 agents in particular, or classes of agents that have benefit. Probably the most important is the calcium channel blockers. At Vanderbilt, typically we use non-dihydrogen calcium channel blockers versus the dihydrogen calcium channel blockers. Actually, the other way around, I'm sorry. Dihydropyridine calcium channel blockers, because we do not want the 3A4 drug interactions. So drugs like verapamil and diltiazem will interact through the 3A4 and raise your cyclosporin or Prograf levels. If a patient or a primary care provider reduces the dose for any reason or increases the dose for any reason, you're going to get acute toxicity. Plus, those drugs, they're negatively chronotropic and inotropic to their hearts, so in some patients it may exacerbate CHF. We use a lot of nifedipine, in some cases amlodipine. What's been shown is that these drugs vasodilate the arterial vasculature. They obviate a lot of the toxicity, the vasoconstriction that occurs with calcineurin inhibitors. So in most of these instances, we actually give it BID. We try to give it every 12 hours to make sure they have maximal vasodilatory benefit more than just the blood pressure control alone. To a lesser extent, the RAS blockade agents have been shown to be antifibrotic in these patients. It's certainly antiproteinuric, and most agree that proteinuria, even in a transplant, is not a good thing. We tend to use ARBs over ACEs. They're better tolerated, they're longer acting, and we see less hyperkalemia with it, and of course less cough. As they're generic now, it seems to be well tolerated and relatively cheap. What about mineral bone management in these patients? Well, calcitriol has shown to improve outcomes in patients who have elevated PTH. It lowers the medial arterial calcification that will occur. Once it occurs, even after transplant, whatever happened while they're on dialysis, whether that reverses or not is controversial. But monitoring the PTH and using whatever methods you need to control it, and even doing parathyroidectomies in patients who do not resolve or benefit from the transplant after a year's time has improved outcomes as well. What about metabolic acidosis? This can be from CNIs, this could be from diarrhea, it could be from the high protein diet. And treatment's been shown to improve muscle mass, bone health, and the anemia. And anemia is directly correlated to outcomes as well. And it's shown actually the ideal hemoglobin should be better than 12.5. Then a study looking at 11 versus 12.5 hemoglobin had better outcomes. Now, unfortunately, as all of you know, we're not allowed to give too much EPO to get their hematocrits that high or hemoglobins that high, but it does seem to benefit them if you aggressively attack their anemia. And lastly, aspirin and antioxidants may have some benefit. All of the data that I just mentioned, most of it's retrospective, some of it's small series, but that's the current thought. So the questions to consider once the allograft has failed: should you do hemo versus PD? And I'll get to that. When to initiate dialysis, should it be early or late? And it's actually been found later is better. There's no survival advantage of starting someone above a GFR of 15. So we usually wait for them to have symptomatology or early symptomatology. We prepare them when we know they're losing GFR, but typically GFR is closer to 10, or typically when we'll start them back on dialysis. When is the patient a candidate for retransplantation? Well, that's a loaded question. By rule, they have to have a GFR equal or less than 20 to get back on the list. People play games with that sometimes in terms of their estimated GFR measurements, MD, RD versus Krakow-Gault, forget about one urine collection, something like that, to lower their 24-hour urine. But nonetheless, 20 is the legal number. You could argue to get patients on a list, and you can do that if you make the argument to the transplant center because they show other signs of uremia at a higher GFR. But sometimes you don't want them necessarily to get a retransplant right away. It's been shown that patients who fail within a year, certainly within a month of getting the first transplant, should not be retransplanted right away. You don't know how sensitized they're going to get, so you don't know what antibodies are going to form. And these patients are so inflamed sometimes from that event that you want some time to settle out. In addition to that, there are patients who have FSGS recurrence or other issues, or BK virus, which most would say should be out of their system before you put a fresh kidney back into the transplant. So there are times when you do want to wait. For the most part, though, you do want a preemptive transplant if they're a candidate for it. How should you, or should you even taper the immunosuppression? I'm going to talk about that in a little more detail in a second. And then should you do nephrectomies or graft preservation? There are some who think you should do nephrectomies in everyone, others think you should keep everything, and others that it's somewhere in between. So what about dialysis modality after transplantation? Similar to CKD, and I'm not going to quote you that literature because I'm not as familiar with it, but patients seem to have some benefit with PD versus hemodialysis in the short term. Long term, there doesn't seem to be a overall benefit. This study suggests a non-statistical significance of PD patients versus who are post-transplant versus control naive patients. It's a small study. They're all single center. This was retrospective. What was interesting, though, is that these patients failed their PD at a significantly higher rate, p-value of 0.02, versus those who were naive. Now, why is that? Interestingly, it wasn't peritonitis. Actually, peritonitis rates were lower in the post-transplant patients, and it wasn't due to membrane problems because their PET studies were no different. So one thought is that these patients aren't psychologically prepared for dialysis again, and they burn out quicker than the patient that was naive in the first place. So one of the recommendations from this paper was to actually make sure you involve social work and psychiatry early when patients have failed their transplant and are returning back to dialysis. On the hemodialysis side, unfortunately, 65% of the patients start with catheters. That could be a problem of the transplant center. It could be a problem of the referring nephrologist or the communication thereof, like who's responsible for this. I think if the transplant patient's seeing the patient, it's not a bad idea to get them an access locally before they return back to the nephrologist. But nonetheless, that hinders their outcomes as well. What about immunosuppression? There's no consensus on how or if you should taper it. What caused the allograft to fail is important. So if you know the patient acutely rejected, does it make sense to taper their immunosuppression when you know the kidney is just going to heat up and get graft dysfunction syndrome? So if someone, especially if it was a bad rejection and you've done everything you can for them, you've given them Rituxan and everything else, and the rebiopsy, you see ongoing cellular rejection, you know you're going to kill the patient if you give them anything else, probably talk to your surgeon to get that kidney out. Chronically rejected kidneys, chronic active vascular rejection, things like that, which you often see in a biopsy, also may heat up as you remove the immunosuppression. If the kidney's not hot, it's hard to convince some surgeons, even at our institution, who do this all the time, to take the kidney out. So sometimes you just have to go through the motions and just watch the patient very closely as they return back to dialysis. Is the living donor imminent? Now, a lot of these patients think they have living donors. You as referring nephrologist may not know, you hear that, but the reality is that the donor really doesn't want to donate, or the donor's not an adequate donor. So it's here, once again, communication with the center is important, because if there is a living donor, why taper the immunosuppression and run the risk of the allograft having to come out? One of the things I'm going to mention is that when the allograft comes out acutely, the PRA goes up acutely, and that can affect their ability to get another transplant. So the cons to withdrawal: you can get acute rejection, as I mentioned, or graft dysfunction syndrome, which leads to nephrectomy. There are some studies that even while the kidney's in there, as you start to withdraw, you will get more sensitized, which lowers their chance to get a second transplant. You may have to get the nephrectomy, as mentioned. And then there's this, it's repeated in the literature, I have never seen it, adrenal insufficiency. I don't know if there's any endocrinologists in the room, but my teaching was always, it takes a lot of steroids, usually more than 30 milligrams daily, for more than 2 weeks daily exposure to affect your axis for up to a year. So patients who have had recent rejections, when maybe they got a ton of steroids, that patient might be at higher risk for adrenal insufficiency if you rapidly taper, especially their prednisone, than those who have not had rejection. So it's talked about but not often seen. What about pros to withdrawing? Infections. So even in patients who are taking very little amounts of CNIs, the retrospective studies suggest 3 times the number of infections independent of line infections. So of course, lines are going to do it, but independent of that, these patients seem to get infections. Malignancies, especially viral-based malignancies, are higher. So anything that has to do with EBV, for example, like the lymphomas or and PTLD, patients who get squamous cell cancers, these are things that are virally mediated, so those seem to increase in patients who persist their immunosuppression beyond the failed allograft. There's costs associated with it, even though these drugs are cheaper now that they've become generic. They're still very expensive, especially for those who don't have insurance, and could be more than $1,000 a month. A lot of transplant centers, including ours, offers grants to the programs. Once they go back to dialysis, that may not be true. And also lab cost and lab monitoring. Even if a patient's on a low dose of CNIs, you have to make sure that there's not drug interactions or toxicity. The Graft there is one of the better studies, a survey that was done in quite a few centers, including ours, and you can see people are all over the place in terms of what they do for immunosuppression. Some take them off everything, some take them off nothing, and then some just do whatever they, depending on the individual patient. So should you do a nephrectomy or graft preservation? Well, the no-brainer is that if the patient has graft dysfunction syndrome, it's got to come out. If it has hyperacute rejection, which is almost mythical status nowadays, I hope you don't see it that often, because we do cross matches before they get the transplants. An acute thrombosis that occurs, we see that unfortunately, especially in lupus patients with hypercoagulable states. We look for that now when we actually give them heparin at the time of surgery if we think they're at risk when the roughened endothelium will cause a graft thrombosis. If that happens, get it out. You need space for a second transplant. That happens. These patients on their 3rd or 4th transplant may have to get one removed. And if there's a renal mass concerning for malignancy, it should come out as well. Should you consider nephrectomy in certain cases? Well, the ones that have early graft loss, some people say up to a year, get it out. I would argue in the first month for sure. If it's beyond that and seems indolent, you could leave it there. or if the histology that you know of displays active rejection, then it should come out. When should you preserve the allograft? When there's benign pathology, when they're asymptomatic, and when there's residual renal function, because especially in PD patients, this may have benefit. The nephrectomy procedure itself carries high mortality and morbidity. Although this is improved, some studies say as much as 11% of these patients will die. So it is a big issue. Nephrectomy leads to sensitization. That's not controversial. 90% of studies show higher sensitization when you take the allograft out. The thought being that free circulating antibodies will occur because the antigen sponge, the antibody sponge, which was the failed allograft, removing it will suddenly raise that PRA and make it difficult to have a second transplant. And does nephrectomy itself offer survival benefit? There's one author in particular who keeps pushing this idea, and if you look closely at the data, the patients with graft dysfunction syndrome benefited from getting their allograft out. I don't think anyone's arguing that. The question is randomizing people who don't have graft dysfunction syndrome, whether there's a benefit, and you'd be less likely to find such a benefit. There is benefits, of course, to residual allograft function after dialysis. There's solute clearance still, there's volume control in these patients, maybe cytokine reduction. They do have improved anemia management, especially in the days when EPO was more expensive. Now it's maybe not as big a deal. There may be nutritional improvement, and they tend to have a better quality of life. So there are guidelines out there, and it's important to know that this is probably the best attempt to try to look at all the data that's out there. But if your kid came home with as many C's and D's as this, you wouldn't be happy. And this is graded information. So this is the best we've got, and I'm sorry I can't offer you better. But the graded information is A to D, with D being very low evidence, and 1 being a recommendation and 2 being a suggestion. So recommendation means a little bit more strength behind it. So they, in 2014, they came up with the idea that if a patient has a transplant or advanced kidney disease, if they have advanced kidney disease and they're looking to start dialysis within 6 to 12 months, you really should get the multidisciplinary team together and involve the referring units as well. So get your nutrition, everyone should be involved. Now we do that all the time, every time from day one, but nonetheless, there seems to be evidence, and I agree with this, that you should agree to look at the CKD issues like I mentioned before, not just the fact that the allograft's failing. You should do retransplantation when appropriate, and they use the data, as I mentioned before, eGFR 10 to 15. Higher morbidity and mortality with retransplantation. If there's a higher morbidity and mortality with retransplantation, since there's a higher morbidity and mortality with retransplantation, look more closely in these patients at the cardiovascular risk and other workup. So in other words, patients who've been on dialysis for a long time and then get a transplant and then they go back onto dialysis, their risk of death is so much higher. Maybe think about CATs, maybe do things that you wouldn't do normally at the transplant center, which is what we do as well. Look, for example, for renal cell cancer. There's as much as 1,600% increase, depending on who you read, of development of ESRD-related RCC, and that goes on despite being a transplant. So you look for that before they get transplanted. Reduce immunosuppression targets to remove the CNI with to remove or lower the targets for CNIs, and then possibly remove it altogether. I agree with that. So we believe in coming off the immunosuppression. I'll show you the data in a second. And then possibly perform a biopsy prior to immunosuppression reduction in case they do have rejection. Most biopsies are done for cause. Some centers do maintenance protocol biopsies. Since most don't do that, you don't really know what's going on underneath histologically. After nephrectomy, stop all immunosuppression. Well, that makes absolute sense, except steroids, which you should taper slowly to prevent adrenal crisis. If there's a severe rejection upon tapering the steroids, you should pulse them with steroids and then give them a nephrectomy. Closely follow their PRA, especially with immunosuppression med changes. We do that. Anyone who goes back on the transplant list gets quarterly PRAs, so we know what antibodies are happening in case they get called in for their transplant. Keep their immunosuppression meds if there's a promise of a retransplantation within the next year. Remove immunosuppression meds after failure if the immunosuppression med complications, for example, skin cancer, other cancers, you may want to come off of it. You can even switch to mTOR inhibitors, which have benefit in squamous cell carcinoma. Retransplantation, risk management, no smoking, good evidence for that. Vaccinate your patients, not great evidence, but still do it.
Keep their blood pressures controlled. They seem to live longer with that. Lipids, there's some data, especially with pravastatin and fluvastatin, and something called the ALERT study, showed a 29% reduction in cardiovascular events in 7 years if the transplant patient is on these agents. You want the more hydrophilic agents. If that doesn't work, doesn't get them to LDL gold, then you can use rosuvastatin or atorvastatin. Avoid simvastatin and lovastatin, which cause rhabdo, especially with cyclosporin at high rates. Diet, as I mentioned before, anemia, as I mentioned before, skin exam for looking for cancers, and also viruses. And in patients who are diabetic, it's very hard to manage diabetics with failing kidney function. As we always say, the only good thing about kidney failure is your diabetes gets better. And that's true because circulating insulin hangs around longer. But some of these patients, really, they don't have the ability to produce glucose anymore from their gluconeogenesis from the failing transplant. You should get an endocrinologist early, and I agree with that. So retransplantation offers the best survival and quality of life. This is the only 1A recommendation and optimal results with well-matched living donors, so there's no doubt there. What about the Vandable experience? I went back, it was quite a bit of work. We went back to 1983. I mean, we had to look on microfiche for some of these cases. But anyway, from 1983 to 2002, this was published back in 2003, 2,300 transplants, 345 had failed allografts. These are not people who died. They went back to dialysis and had failed transplants. And 273 ultimately needed or 79% needed a nephrectomy, 50% within the first year. Now remember, that's a different era of immunosuppression. It was back in the old Imuran prednisone days, and then cyclosporin. Maybe it's not as high now that we use tacrolimus. But the histology did show over 80% had acute rejection and should have come out, and their presenting symptomatology primarily was fever, followed by graft pain and hematuria. Our old regimen was to stop the antimetabolite at the time of dialysis, taper the CNI or the mTOR over a month, and then remove the prednisone in another month. Our new regimen that seems to work a lot better is to do the same thing, except we do not stop the prednisone. We keep the patients on 5 milligrams of prednisone, very innocuous, no evidence of increased infections from 5 milligrams of prednisone. Maybe their bones are a little bit worse from this, but overall, these patients seem to be keeping their allografts, as yet unpublished, but soon to be published. Less than 10% get immunologic rejection and required nephrectomy. So what about returning the patient to the community nephrologist? Every center is different. A lot of, especially surgery-driven centers, will kick the patient out almost immediately, and the transplant center is not involved, which is a shame. The same thing if the referring nephrologist isn't ever involved, especially when the patients live far away. So I think at whatever the situation is, at your final visit at the transplant center, you should ask yourself the question, is the patient a retransplant eligible candidate, and have they been referred? Make sure you do that, because there'll be a lag if they go back to the to the general nephrologist. 2, discuss the final immunosuppression taper with the patient, and make sure they understand that it is not to be changed, that the local nephrologist is going to have to honor this, put it in your discharge summary to the nephrologist, and you should tell the patient and review the signs and symptoms of graft dysfunction syndrome so they can report, not wait for someone locally to make the diagnosis if they need to come back to the center. And then help get that proper dialysis access ready. The responsibility of the community nephrologist, recognize the graft dysfunction syndrome, like I mentioned before, alert the transplant center when this occurs, and maintain the immunosuppression regimen as recommended. So this is something that's never been published, but we've done it. It's been a CPC locally, and we're going to publish it. But this is a future of possibly transplantation. There is now cell-free DNA testing. If you're not familiar with this, cell-free DNA testing is why we don't have to do amniocentesis anymore. Cell-free DNA testing may pick up cancers. There's a hope that maybe mammograms will go by the wayside and everything. That's an applause, right? So cell-free DNA picks up foreign DNA and your host DNA because cells turn over at a certain rate all the time. So there's 2 companies making that do a test for transplants. They have both independently validated their data, showing that cell-free DNA can, if it gets more than 1% foreign, meaning that the allograft is injured, it means that the allograft's rejecting. So here's a case, and this actually occurred within the same week. 2 calls were received for acute hematuria in patients from 2 separate nephrologists, in patients who live far away. We attract from 22 states. We have patients who live sometimes 8 hours away before they come to Vanderbilt for their 15-minute office visit. But nonetheless, they both had failed allografts and live locally. Patient 1 was a 58-year-old black female. She had a deceased donor kidney transplant for 12 years. She had been on hemodialysis for 7 months and was told to continue her prednisone indefinitely. Her lost allograft was due to non-immunologic cause. It was CAN or IFTA. The second patient is a 36-year-old Asian male with a deceased kidney transplant, kept for 11 years, on hemodialysis 9 months, and told to continue the prednisone indefinitely as well. Also lost the allograft due to non-immunologic causes, and it was due to recurrent IgA nephropathy. Both of them presented with hematuria. Their grafts were not hot. It wasn't graft dysfunction syndrome in the classic sense, so it wasn't clear whether these patients needed to have a nephrectomy. Now, I physically did not see these patients. I ordered that cell-free DNA test, which you can do anywhere. And so patient 1 had a low cell-free DNA percentage of 0.21%, and the observed hematuria actually resolved and never became symptomatic. Patient 2, though, had a high cell-free DNA, and we asked the patient to come in, and nephrectomy did show severe cellular and vascular rejection. So this may be the future for these borderline cases. So in conclusion, well-designed studies that address failing allograft management are lacking. Aggressively address CKD management and medical concerns and preserve residual renal function when possible. Appropriately prepare your patients for dialysis or retransplantation. Determine the best immunosuppression tapering strategy. I gave you my 2 cents. I believe that keeping these patients on prednisone forever is the way to go if you're trying to keep that allograft in place, but get them off of everything else eventually. Sometimes that changes based on the clinical scenario. Recognize graft dysfunction syndrome and the need for nephrectomy, whether you're the referring nephrologist or the center, and seamlessly transition your care between the transplant center and community nephrologists, yet maintain communication as needed. And the question is this the end? Thank you. So for those of you who don't know, this is from Monty Python. And just this morning, one of the members passed away, Terry Jones, so I thought it was appropriate. And it's a famous scene from a movie called The Holy Grail, 1975. Probably more of the guys know what I'm talking about. And the scene is where it's during the bubonic plague, and the person is asking, bring out your dead, bring out your dead. And someone is throwing dead onto the cart, and the guy goes, I'm not dead yet. And you can picture that being the transplanted kidney. I'm not dead yet. And so I'm getting better, anyway. And you can argue who's the community nephrologist or the transplant nephrologist, but nonetheless, don't kill the kidneys too early. Thank you.